took care of a few details. We're very happy to welcome you to today's ICAP Grand Rounds, where we're going to be talking about the state of the Mpox epidemic, and we'll be sharing global, national, and local perspectives. As many of you may know, globally, there have been nearly 100,000 Mpox cases that have been reported since May of 2022, so just a little bit over 2 years ago. And these cases have affected gay, bisexual, and other men who have sex with men. There's been a combination of behavioral changes and vaccination efforts in response to the outbreak. But a more concerning version of Mpox is currently fueling a surge of cases in the Democratic Republic of Congo. So today we have several different experts who are going to talk to us. We can have the next slide. Let's go ahead. And I'm sorry, I didn't introduce myself. I'm Dr. Jessica Justman, the Senior Technical Director at ICAP. And I'm very, very pleased today that we're going to be hearing from these three individuals. We have Jennifer McQuiston, who serves as the Deputy Director of the Division of High Consequence Pathogens and Pathology at the U.S. Centers for Disease Control and Prevention. This part of CDC investigates and responds to infectious disease outbreaks that pose significant consequences to public health and safety. Dr. McQuiston has spent over 25 years at the CDC investigating outbreaks of dangerous pathogens, especially those with zoonotic sources. And she has served as the incident manager for CDC's response to Mpox during the 2022 and 2024 outbreaks. After Dr. McQuiston speaks, we're going to hear from Dr. Placide Umbala. Dr. Placide is an associate professor in the Faculty of Medicine at the University of Kinshasa, and he's the head of epidemiology and global health and the director of the Clinical Research Center at the National Institute of Biomedical Research in the Democratic Republic of Congo, or DRC. He has extensive experience in medical biology and specific training and expertise in microbiology, virology, and outbreak investigations. And he's currently co-leading several research studies on Mpox in the DRC, including a clinical trial on the efficacy of tecovirimat for the treatment of Mpox in adults and children in the DRC. And then our third speaker is Joey Platt, who's a senior project officer here at ICAP. And she has several years of research experience coordinating studies on HIV prevention, substance use, COVID-19, and more recently, Mpox. As co-investigator of ICAP's Mpox seroprevalence study, Joey led the design and implementation of this community survey among men who have sex with men and transgender and non-binary individuals in New York City. So I think you can agree that we have three extremely well-positioned individuals to talk to us about the current state of affairs with Mpox. So Dr. McQuiston will lead us off. I think we can go, yes, let's please switch over to Dr. McQuiston. Thank you very much. You need to unmute, Jennifer.
Apologies for my technical ineptness. Really happy to be here today to speak with everybody. I have the privilege of kind of launching us into a discussion of Mpox. It is an ongoing public health risk, both here in the United States and globally. And it's something that at CDC we've been working on for several decades, and we've been working very closely with Dr. Placide in the Democratic Republic of Congo. So I'm happy to be able to share the stage with him today. I'm going to start with an overview of Mpox. So Mpox is an orthopox virus caused by the monkeypox virus, which is going to be abbreviated MPX.
Can you share your slides? Share your screen.
Oh, okay. I really apologize. I want to
Thank
I
you.
want to assure everyone that we did practice this before we started. Again. Is everything okay now?
Perfect. Thank you.
Excellent. Okay, it is a member of the orthopoxvirus genus, and this is the same family as variola virus, which causes smallpox. And it's one of the reasons we're so concerned about Mpox around the world. The symptoms are similar to smallpox, but generally milder, and there are two different clades of Mpox that have variations in where they occur naturally and the severity of their presentation. So there is clade 1 Mpox, which used to be called Congo Basin, and it's found in Central Africa. And there is clade 2 Mpox, which used to be called West African clade. It's found naturally in West African countries, but was responsible for the global epidemic of Mpox that spread through MSM predominantly MSM in 2022. Immunocompromise in any form can cause prolonged life-threatening infection with both clades. But in general, clade 1 tends to be more severe and can cause deaths in a higher proportion of the people that it infects. Historical estimates of case fatality rate for clade 1 have been between 1 and 11%. And clade 2 is less severe. The variant called clade 2B, which was responsible for that global outbreak that started in 2022, had in the United States about a 0.2% case fatality rate. So it was quite lower, but I think any death due to Mpox, because it is preventable, is one too many, and that's one of the reasons that we are working hard on this. Mpox generally spreads through close contact, so that can include intimate contact, and the 2022 outbreak was predominantly a sexually transmitted infection that was causing that outbreak, but it can also be spread through direct contact with contaminated bed linens or clothing or materials. So both of those ways are ways that Mpox can spread. And then in countries where this occurs naturally, animals are the reservoir, wild animals, usually going to be a rodent of some kind, although we don't really know what the actual reservoir is yet. There has been shown to be in a lot of different rodent species in the wild. Contact with those wild animals can also spread Mpox. This is the 2022 to present outbreak of clade 2B in the United States. So you can see that we had a very dramatic outbreak peak, started in May of 2022 and began to really wrap up by November of 2022. And we've continued to have ongoing low levels of cases during 2023 and into 2024. On average, we're seeing about 59 cases a week in the United States right now, so it's just a reminder that this is not an outbreak that is over. We've had a very robust domestic response to the clade 2B Mpox outbreak. You can see here over 1.2 million vaccine doses administered, a lot of educational efforts underway to help people become aware of Mpox and what they can do to protect themselves. Nearly 150,000 specimen tests performed by the LRN, more by commercial laboratories, and over 1,400 CDC responders worked on the Mpox response from 2022 to present. Vaccine has been a mainstay of our domestic mitigation strategy. You can see here that when vaccine did become more available in the US starting in early July, there was a very enthusiastic uptake of the first dose of vaccine. This is a 2-dose vaccine though, and so a smaller proportion of people got that second dose of vaccine. And I think that overall, only about 25% of the individuals who have been identified as having to be recommended to get this vaccine to prevent Mpox have gotten both doses. So we continue to have an under-vaccinated population here in the United States for persons who might have specific sexual behaviors that place them at risk for Mpox. And the vaccine is working, it's continuing to work. There are a series of studies that look at vaccine efficacy that show that 2 full doses of vaccination have quite striking efficacy. No vaccine is 100% effective, so there are some vaccine breakthroughs, but we're not seeing an increasing number of those over time. So we're not getting really any signals that immunity is starting to wane or that there's a need for a booster dose at this time. And I think in general, we continue to see that 2 full doses plus behavioral strategies to reduce risk continue to be protective for people. And I do want to point out that we do have data supporting that only 1 dose, which is a partial vaccination, has a lower efficacy. ACIP, which is the Advisory Committee for Immunization Practices, has weighed in on JYNNEOS, and they do recommend vaccine for people with certain sexual risk factors. This slide goes into who is recommended as part of ACIP's routine immunization schedule. This is now a commercially available vaccine, and it's going to be starting increasingly available in pharmacies around the country. So I think any reluctance on people's part to get it will hopefully will start to address that through sort of this more routine availability, rather than people having to wait for a specialized clinic pop-up of some kind. And I think because it's on the routine immunization schedule now, when they visit their regular doctor, they can have a conversation about what vaccines they need to be considering. We have a lot of lessons from the 2022 Mpox response. I think the first was that it's really important to take an approach that deeply engages the community most affected. So the community of gay, bisexual, and other men who have sex with men are a group that are very active in advocacy, and they want to be able to provide their input and give their feedback on what they see as government work that's impacting their community. And I think that involves not only targeting them for messaging, but listening and taking that feedback and then keeping the public health response flexible and responsive. And so we heard during our response that the types of messaging we were giving were not resonating, and we were able to work with communities to modify that messaging and make sure that we were putting it out in ways that worked. That also includes listening to doctors. We heard that they didn't want to use our laboratory response network labs, which already had good access to testing for Mpox, but they wanted to be able to use their familiar laboratory. So that meant that we had to rapidly expand our tests to get into commercial laboratories. I also think we learned that it's really important to keep our resources and investments flexible. There's no Mpox funding. Congress doesn't have a line that funds Mpox. And so because this was being spread through sexual transmission, and it was impacting a population of individuals that were also at risk for other sexually transmitted infections, working with our National Center for STD Prevention here at CDC was really important, because it allowed us to take a endemic approach and to combine our recommendations with other inactivities and mechanisms that might be better funded, such as HIV prevention. And then I just want to call out another lesson was the need to continue to invest in foundational research. So the only reason we had a vaccine ready to go was because JYNNEOS had been studied for decades as a smallpox prevention tool. We had an experimental therapeutic called TPOXX, or tecovirimat, that was available through an investigational new drug permit for use because of this type of research. But one of the things we saw during the Mpox response in 2022 is we're starting to see some tecovirimat resistance emerging, and that's one of the only main drugs that we have in our arsenal. So continued foundational research is going to be important to make sure we have all the tools we need, because I do predict Mpox is going to continue to evolve and challenge us. Importantly, clade 2 Mpox is not over. I mentioned that we continue to have about 59 cases per week. These continue to be mainly in cisgender men who identify as gay or bisexual. They continue to be mainly in unvaccinated people or people who only got 1 dose. We continue to see fatalities in the United States, and I think severe immunocompromised, particularly people who might have unrecognized or untreated HIV, that remains a very significant risk for fatal outcome. And I did mention that we were starting to see some emergence of TPOXX resistance. I mentioned JYNNEOS was commercially available, and I do want to call out that the national stockpile availability is going to be phased out by August. So that means that other ways of state and local engagement in making commercial JYNNEOS available to individuals and helping overcome equity and access issues is going to be important in that new commercial space. And then I also mentioned we're not recommending a booster at this time, but we're continuing to monitor the epidemiologic signals to see when and how. Some of the work that we're doing to encourage vaccination, we have a CDC Foundation partner campaign with Ballroom Vogue influencer Deshaun Wesley, who was originally somebody who worked in public health before he became a bit more of a star. And he did a great campaign with the CDC Foundation emphasizing the importance of 2 doses. We had 2 MMWRs that have come out recently highlighting some of the science around Mpox, including the ongoing state of clade 2 in the US and also what we were seeing in terms of vaccine breakthroughs. We've also been doing some modeling that indicate that increasing immunity is critical to minimize the potential future size of outbreaks of either clade 1 or clade 2 should they start to kind of ramp up again. And so communities can acquire those higher immunity levels not only through counting who may have already gotten Mpox, but bumping up vaccination status. And we are partnering with the HHS Office of the Assistant Secretary for Health with a Summer of Pride partnership, which is providing educational and outreach activities at many Pride events across the country this summer. And then I'm just going to quickly touch base. This is going to lead into Dr. Mbala's talk. There is a changing landscape of Mpox. We are seeing increasing cases globally around the world, not only related to clade 2, but in lots of endemic countries. We've recently seen reemergence after 30 to 40 years of no cases. And I think one of the reasons for this is not only that we've got increasing areas of habitat where people might come in contact with wild animals that might spread it, which is shown in this graphic on the right, but we also have a global population immunity to orthopox viruses that is increasingly getting lower and lower year after year. So most people around the world were vaccinated for smallpox in the first half of the 20th century. I'm one of the first generation of children that did not get a smallpox vaccine. And as that population ages out and we have a much younger population growing who've never gotten a smallpox vaccine, our global estimated population immunity to orthopox viruses is less than 20% right now. And the graphic on the left shows that the R0 value, which is the reproductive value for monkeypox virus, is estimated to be upwards of 2 in a setting where there's low population immunity. And that is potential pandemic level circulation reproductive numbers. So that might be one of the reasons why we are seeing some of what we're seeing around the globe right now and why we're concerned. And I mentioned these are just some of the reasons why I do think that we can't discount increasing human exposure to Mpox through deforestation, climate change, but I also think that waning population immunity is really important. And then leading into Dr. Mbala's talk, we are watching what's happening in the DRC. Right now, no cases of clade 1 Mpox have been reported in the United States or in Europe, but I do think there's a risk for potential spillover, and there's a window of time for DRC to take partners and work hard to help stop what's happening in that country. There have been over 22,000 cases since 2023. It is endemic there, but I think what they're seeing is outside of anything they expect for normal endemic spread. And I think the goal is to prevent this from becoming a new global Mpox outbreak. One of the things that we've done in the US to prepare for the possibility of clade 1 spilling out is saying that clade 2 preparedness is clade 1 preparedness. If somebody's getting that vaccine, they're going to be prepared regardless of clade. It's going to protect against both clades. And we have issued a health alert notice trying to urge clinicians to think about Mpox if they see symptoms in people who are returning from the DRC and get expedited clade-specific testing. And we have increased our capacity to look for clade 1, both through some wastewater surveillance testing and also our normal testing of Mpox specimens. Every specimen in the US that we are performing either a clade 1 specific test for, or we're ruling it out through a clade 2 test that shows us if it's positive or not. There have been over 4,500 specimens tested since December when we really started to ramp up our surveillance, and to date, no clade 1 has been detected. So in summary, clade 2b is still circulating globally and in the United States. And although the rates are significantly lower than 2022, we've not yet achieved elimination And I think that that's going to require a lot higher vaccination rates and some concerted effort with a goal for elimination. And vaccination and behavioral change remain our key mitigation strategies. For clade 1, the risk for spillover from DRC is there, but right now we've not had any cases reported outside of Africa. And we are encouraging doctors to seek clade-specific testing, especially for people with a travel history to DRC. And then domestically, we're really pushing vaccines. So any opportunity we can, we want people to get both doses, and communities should be aiming for a greater than 50% immunity to lower their risk for large outbreaks. And that is it for me. Thank you so much.
Thank you so much, Dr. McQuiston. That was really terrific. And I know I have a couple of questions for you, but we'll wait until we have the whole Q&A session at the end. So let's move on now to our next speaker, who I introduced to everybody before. So we have Dr. Placide Mbala from the University of Kinshasa, who's going to talk to us about the Mpox situation going on right now in the DRC. Dr. Mbala, please go ahead and share your screen.
Thank you so much for the floor, Jessica. So I'm going to share my screen. Can you see my screen?
Yes, it's perfect. Thank you.
So I'm going to talk about, I just call it kind of a new epidemiological dynamic of Mpox virus in the Democratic Republic of Congo. So I will start my talk just to remind everyone, Mpox was first discovered in DRC 1970. And that was a kind of a threat for the global smallpox eradication program, because smallpox clinically is the same, almost the same similar presentation with smallpox, and is from the same genus and the same family with smallpox, vaccinia, and cowpox. And this is a kind of a short story of Mpox in the DRC. In 1970, after the discovery of Mpox, there was a kind of passive surveillance conducted by WHO to follow also, at the same time when there was the global eradication of smallpox, to understand if, Mpox can be a threat for us after the eradication of smallpox. And then in 1977, the DRC was certified as smallpox-free country. And in 1980, Mpox was integrated, and other viral hemorrhagic fever among diseases that should be notified in the country. At the same time, in 1981, WHO decided to conduct an active surveillance of Mpox in Africa to understand if now we have eradicated smallpox, does Mpox create a threat, after the eradication of smallpox. And in 1986, this active surveillance was stopped because of lack of resources, but also because they concluded that Mpox was not really a threat for the public health, because most of the cases were animal to human cases, and very small number of secondary cases were reported. But 10 years later, in 1996, there was a huge outbreak of Mpox in Katakokombe in Sankuru province in DRC, where we recorded over 700 cases, with more cases, like about 70% of cases of human transmission. And this raised many questions among the Congolese scientists, but also at the international level to understand what is happening at that time. You know, what is the situation of Mpox, if the virus is changed, and how is the transmission of this virus, why this virus become suddenly more transmissible to human as it was before. So because of that, Professor Muyembe, who is the head of our INRB, our institution, decided to contract with several institutions at the international level to conduct a series of studies. So we focused on the diagnostic of Mpox, ecological of Mpox. We conducted also a trial on the vaccine of Mpox with the CDC. And there are also studies on the epidemiological surveillance of Mpox that was conducted with the NIH and UCLA, and also studies to understand the clinical characterization of Mpox conducted by US Army. And among those studies, we showed at the epidemiological level that Mpox was a huge problem in the country with an incidence more than what was predicted by WHO after the active surveillance in 1986. So almost 20 times compared to what was predicted by WHO. And we showed also that Mpox was prevalent at a forest area compared to the savanna area. And you can see at the right some pictures of the team going to the field to investigate Mpox cases. And the other thing that we mentioned also is the fact that most cases were among non-vaccinated people. And the more we have more non-vaccinated people, the more we have more, I can say, susceptible population because of the declining of the herd immunity among the population. And what we also observe is the fact that the smallpox vaccination still gives a protection over almost 80%. And this is also why in our national policy, we advise that when there is an Mpox patient, that someone vaccinated previously with a smallpox can provide care or help or assist people who are affected by Mpox because they have a certain level of, a good level of protection against this disease. And this is just a few pictures showing what we also observed when we conducted the clinical characterization of Mpox. As you can see, most of cases that we followed had this kind of presentation with lesion diffuse in the body, but more concentrated at the extremity of the body. And you can see that the lesion affect also the sole of the feet, the palm of the hands, and they can be also seen in the mucosal inside the mouth. And we also observe some of the complication, high complication in most of the case, and also other type of complication, mucocutaneous complication. We also observe some fetal demise among the 5 pregnant women that we follow for the kind of spontaneous abortion. And so this is what we learn, and we continue to follow Mpox in the country, and here is the situation that we have right now in the country. As you can see, since 1996, we had a sporadic, I can say, Mpox outbreak in the country, and a huge outbreak we observed since, I can say, 2020, 2022, and a huge, I can say, increase of number of cases in 2023. And also this occurred not only in endemic area of the country, but also affected other part of the country where we did not have Mpox cases before, like as you can see in yellow. And you can see on the map at the right, in green, it's the forest, and you see most of the cases are close to the forest area. So we have more, I can say, zoonotic cases, so zoonotic spillover cases, leading to like several outbreaks in several places. But we are also since last year, the end of last year, we are observing some cases of sustained human-to-human cases, what we will talk about in a few minutes. And here you can see that the number of cases is still increasing. If we compare this year with the two previous years, you can see that even during the first 16 week, the number of cases this year seems very high compared to the two previous years. And right now, since the beginning of this year, we have already more than 9,000 reported cases, and a mortality rate around 4.3%. And what is see, it's a bit alarming here. It's the fact that we are seeing a kind of sustained transmission among humans at the eastern part of the country. And this part is mostly a kind of mining zone and mostly urban compared to where we observe, most of outbreak of Mpox, where it's most village cities around the forest. But here it's more urban, and there are less contact with bushmeat, and as it is a mining zone, there is a lot of commercial activity and sexual activities, and most of those sex workers are from other countries like Burundi, Rwanda, Tanzania. So they used to travel to DRC for work and also to look for money. And the fact that what is also, I can say, striking is that the fact that here we are having more cases among young adults and adolescents compared to the zoonotic or the endemic part of the country, where we have more young children, less than 15 years old are affected. And as you can see, there are also about between like 30 and 50% sex worker affected in this area, and they report mostly sexual contact being kind of the most probable cause of transmission of Mpox in this area. So we are facing this kind of situation, the east part of the country. And when we compare this data or samples that we receive, the sequences we receive from this part of the country with the other part of the country, you can see that those sequences that you see, the clade 1b that we suggest as the name that we suggested, those sequences seem grouping together outside the other clade 1a that we used to to detect in the country. So this is why we try to investigate more, and we found out that those sequences seems to have a kind of accumulation of ApoB3 mutation that may explain why those sequences or this virus has the capability to easily transmit from human to human. So is the situation also in South Kivu, where we have this kind of sub-clade appearing there. So the number of cases is still increasing. At the beginning of this outbreak there, we had about 10 cases per week. Now we are almost over, this is at week 21, at week 24 last week, we are about more than 100 cases per week. And as you can see on the map, cases are not only as it was the beginning in Kamituga, the big circle that you are seeing, but there are also cases close to other countries like Burundi, Rwanda. And this is also alarming because this can be a trigger for a spread of the disease in other countries or beyond the region. And the risk of, as I say, of a larger outbreak is the fact that we are still seeing cases there. There are also cases, new cases detected in Goma, which is another province close to Sud Kivu. And Goma is open to the international countries because there are international flights, and also because of the presence of refugee camps in Goma. So this can be a risk for a large outbreak, but also because the response is not well set up there. There are significant loss of follow-up, significant support to the sex worker, and also the traffic and trade between those different countries create a kind of an alarming situation in this region. And so we are now facing this situation in a country where we have I can say, the epidemiological, the former or the former epidemiological situation of Mpox in the country, and the new situation where we can have very few lesions and the most concentrated in the genital part, which will run the diagnostic, clinical diagnostic a bit difficult. So meaning that this situation will lead to some of the changes in our control strategy. The case definition need to be revised. The diagnostic method, as the new sequences can we find some deletion in the new sequences that can be difficult to be detected using some of the specific PCR that we can use. And also the preventive measure need to be revised, since we now have different type of population affected, and we need to think about how to prioritize our strategy, the case management, the disease survey strategy, and also the strategy for epidemic, for the response to the outbreak. So those are a few, I can say, strategy that need to be revised, since other programs need to be involved, like the HIV, the STI program. And as I said, there is a risk of a regional outbreak even beyond the region. So we need to think about how to work with other countries to strengthen the surveillance at the regional level, but also to include all the type of a vertical program, in charge of HIV, STI, and we have to train our clinician to be able to detect the different cases of Mpox, but also how to approach the key population, avoiding stigma, and also to get the commitment of this affected population. So I think I will stop here, and these are a few questions that we can still ask ourselves as we are seeing, a kind of a new dynamic of this outbreak. So we need to think about if how the vaccines can be effective, and also what could be the role of asymptomatic infection and the reservoir of the virus. It's a very big question that we need to continue to investigate, since we have different variants, different sublineage, and different clades. So we need also to think about what could be the effectiveness of the vaccine, for example, among when we have post-exposure situation, and also other vaccines that can be also effective, that can be used. As we know right now, for example, Genius is not approved yet for young children, and most of the affected population in our country are young children. So we also need, a vaccine to be sure that a vaccine that can be used for young children, and also this spectrum of Mpox-associated illness, and also what could be the risk factor for severe illness. And we need to think about also the case management, what kind of treatment that can be effective. There are clinical trials that are ongoing, so we are waiting to see the result. But also we do not need to forget about the supportive care, as we showed during our study in 2007 to 2011, that just with a good supportive care, we were able to reduce significantly the mortality of among Mpox patients. So thank you so much for your attention, and we are ready to take questions.
Well, thank you very much, Dr. Mbala. I want to just remind our audience that because we have, 3 really terrific presentations, this webinar is scheduled to run until 10:15. So we're going to have one more talk from Joey Platt, and then we're going to take questions. So I hope that as many of you as possible will be able to stay on for that last additional 15 minutes, which will run from 10 to 10:15 Eastern Time. Joey, please, would you go ahead and tell us about the survey that you and I and many others worked on last summer. Thanks.
Yes, it's my pleasure. Thanks, Jessica. Thank you, everyone, for giving me the opportunity to present findings from ICAP's community survey on Mpox vaccination. As Jessica mentioned, I had the pleasure of leading it under her as co-investigator of the study. And it was just about 1 year ago, actually, that we launched this survey during NYC Pride of 2023. So I'm excited this Pride Month to share kind of what we found out from this survey. So thanks to Dr. McQuiston and Dr. Mbala, you have a good idea of the Mpox situation globally and in DRC, which remains urgent and warrants both global action and attention. I will now zoom in, though, on the Mpox outbreak in NYC, which began in the summer of 2022, and that was actually when this study was conceptualized. For those who are in New York City, you might remember that New York City was one of the most impacted areas with over 3,800 cases reported. Gay and bisexual men who have sex with men were disproportionately impacted, representing a large majority of these cases. And also during the time, at the peak of the outbreak, response was hampered by limited and delayed access to testing and vaccination, a lack of awareness among healthcare providers, and a related stigma. Thus, community impact of the outbreak and effectiveness of the public health response warrant further exploration. As of recent, there has been a small increase in Mpox cases in the city, although cases remain relatively low, but it does pale in comparison to what's happening globally and in the Democratic Republic of Congo. I want to first acknowledge that in NYC specifically, and in the US, Mpox was largely brought under control by community-driven and activist-led responses in the city, including awareness and vaccine campaigns and behavioral strategies, some of which have been highlighted in some of these scholarly and news articles shown here. During the 2022 outbreak, marginalized communities were disproportionately impacted by Mpox, particularly Black and Latinx MSM communities and individuals were overrepresented in cases, as you can see here in these graphs. There were also vaccine inequities, with Black and Latinx individuals being less vaccinated compared to white individuals. It's important to note that both of these health inequities are largely due to historical and present day systems of oppression and injustices that hinder healthcare access. The primary objective of our study was actually to estimate seroprevalence of Mpox and orthopox virus antibodies among men, transgender persons, and non-binary individuals in NYC. And we did achieve this aim, and results will be presented next month at the International AIDS Conference in Munich, Germany. So stay tuned for those. Today, we will focus on the objectives shown in the red box, which are in regard to vaccination and the characteristics of our population. So we looked at accessibility, uptake, and attitudes surrounding Mpox testing, treatment, and vaccination, and then also assessed anticipated attitudes and practices in the event of another Mpox outbreak in the city. So to achieve our aims, we conducted a cross-sectional survey from June to December 2023. We recruited a purposes sample, which means we were intentional in recruiting from locations with large lesbian, gay, bisexual, transgender, and queer populations. Oh, sorry, and that's a little cut off. So we were familiar with these areas. We consulted the community and also had queer identifying folks on the study team. And we recruited in neighborhoods such as Hell's Kitchen, West Village, and Chelsea in New York. And you can see these areas in the darker purple on this graph, which represent the highest concentration of same-sex households in New York City. For eligibility, participants were consenting adults who were self-identified as men, transgender, non-binary, or gender-diverse individuals that were asymptomatic for Mpox, currently residing in NYC, and reported being sexually active with one or more male partners in the last year. And also, I realized I forgot to mention, for the primary objectives, the CDC is actually conducting the serology testing for these results, which I said will be presented next month at the AIDS conference. So given the community-based nature of the study and that we would be kind of embedded in the community on the street, interacting with participants who might be interested in participating, we knew we had to have a creative and compelling recruitment approach. And this is where McCann Global Health came in. We partnered with a communications agency to develop a campaign for the study, something that spoke to the queer community, drew upon their activist roots, and came up with some clever catchphrases, as you can see here, under the umbrella of Do It for New York. So do it with pride, fill out a questionnaire, donate some blood, help keep Mpox out of New York. You can see another one here, do it in a New York minute, do it after brunch, do it in heels. We had this colorful campaign and kind of worked to develop a brand identity for the study that made it appealing for participants to participate. The study was perhaps most unique because of its recruitment approach, with the goal of surveying the general community as opposed to like a clinic-based population. We recruited and conducted study visits street side, outside or near venues that often serve the LGBTQ community. Participants were approached, greeted, and given a pitch about the study. This pitch became quite an art form during our study recruitment period. And if interested and screened eligible, participants were consented, administered the questionnaire, provided a blood sample, and then were reimbursed for their effort. And here's some pictures of us in action. The questionnaire was administered by trained interviewers using tablets. We often found secluded spaces in our outdoor locations for this to happen. You can see the questionnaire modules listed here. We asked participants about demographics, vaccination history, sexual health, Mpox health history, Mpox vaccination, and knowledge and attitudes. After they completed the survey, they provided 4 milliliters of blood collected by a trained study phlebotomist in the privacy of a tent we had set up there. And then the blood would be transported and processed at the end of each day in the ICAP Bronx and Harlem Prevention Laboratories. After they completed the survey, participants received $35 for their time and effort, and were also offered resources on how to protect themselves from Mpox and how to get vaccinated if they weren't and were interested. Now to move on to the findings of the questionnaire, starting first with participant characteristics. We screened 570 people, of which 308 participants were enrolled from 16 different venues around the city in those neighborhoods I mentioned earlier. And this took place over a period of 87 days. As you can see, participants were pretty diverse in age and race, with the greatest proportion being in their 30s and white. The sample was primarily cis male and identified as gay or same gender loving. And although not shown here, participants mostly lived in Manhattan and had completed secondary education. And compared to the most recent published description of this same population in New York City overall, we found that our study group was more racially diverse, slightly older in age, and reported a lower education level and total household income. That's good to know. And moving on to Mpox vaccination. As you can see, Mpox vaccination coverage was moderate, yet similar to the US coverage and NYC 2-dose coverage. Less than half participants reported receiving this 2-dose recommended series. And we'll explain why this was. We explored a little bit of vaccine hesitancy in the next slides. To dive a bit deeper into vaccine uptake, we assessed vaccination by key participant characteristics, particularly in terms of gender and sexual orientation. Differences, or rather inequities, emerged. As you can see here in the blue bars, transgender and gender nonconforming or non-binary, along with bisexual participants, were less vaccinated compared to their cis male gay counterparts. So that's an inequity we discovered when analyzing this data. And this also is in line with city data as well. The similar inequities were also observed among racial and ethnic groups. Latinx and Black participants were the least vaccinated for 2-dose coverage, with 21% and 26% respectively receiving 2 doses compared to 60% of white participants. This inequity has had a lasting impact when you consider that cases in the most recent uptake in the city have been among those who've received 1 dose or no dose. Furthermore, as you can see here, results revealed that vaccine coverage was lowest among those who had achieved lower levels of education, reported working but not formally employed, and who had unstable housing, all underscoring the role of social determinants of health and receiving health interventions such as vaccination. So as I mentioned, we looked at attitudes for why individuals decided not to get vaccinated. And here are some of the top reasons, top 4 reasons. One being they don't think they're at risk for Mpox. About 20% of participants who hadn't received the vaccine thought that. 13% didn't know where or how to get vaccinated. And then 11% thought Mpox cases were low in NYC, which was true at the time. And 11% were worried about the vaccine side effects. To assess accessibility of the Mpox vaccine, we also asked unvaccinated participants how confident they felt in their ability to receive the vaccine. And 21% of unvaccinated participants expressed low confidence when asked if they felt confident in their ability to access the vaccine. When we asked about barriers, not knowing where to get vaccinated emerged as a top barrier at 72%. Along with getting an appointment, sites not being open at convenient times, or sites not being located in their areas. At the time of the survey, there were, as there are today, concerns of another Mpox resurgence in the city. Therefore, we wanted to understand vaccine intentions, including a booster dose if it was to be recommended. And we asked this with the hope of informing future response strategies. We found that overall participants reported high intention and likelihood in receiving an Mpox booster, second dose, or first-time dose in the event of another outbreak. And you can see that here with the top bars. So in conclusion, we found that venue and community-based recruitment and study implementation was challenging, yet feasible for this population. And we found the Mpox coverage was similar to two-dose coverage in NYC of 47%, and differed by key social determinants of health, including race and ethnicity, education, employment, and housing status. This underscores the need to address these structural barriers and reduce these structural barriers often faced by marginalized communities in accessing healthcare, including Mpox vaccination. Mpox risk perception was influential in participants' decisions to not get vaccinated, and thinking that Mpox cases were low. We also heard anecdotally that people thought they maybe weren't at risk for Mpox. So that can also inform educational and vaccination campaigns and strategies. And then lastly, in the event of another large Mpox outbreak in New York City, willingness to get vaccinated is high, which is good. I want to close by just acknowledging the Mpox study team for all their hard work, specifically Connor Wright, who is joining us today. He is at UCLA pursuing his PhD, but he was co-investigator with me on this study, so I want to give him a huge shout out. And then, of course, the study participants. We really got to know the community being out there on the street and talking to people about how the Mpox outbreak affected them and why they felt compelled to participate. And then our funders, AMFAR, New York City Community Trust, Maryland School of Public Health, McCann Global Health, who developed that campaign first pro bono. And then, of course, the ICAP Harlem Prevention Center and Bronx Prevention Center staff who conducted study visits at their site and processed and transferred the blood samples. Thank you to all. And I will take questions.
Okay, thank you so much, Joey. So we have several questions that have been posted, and I will also encourage people, if they prefer, they can just sort of raise their hand through the Zoom function, and we can make your microphone active so that you can ask the question. But I'll start out first with a question for either Dr. Mbala or Dr. McQuiston might want to comment on this, or maybe both of you. Any data or perspectives on reinfections, people who've gotten Mpox a second time, and whether there's evidence that that is due to waning of infection-derived immunity?
I'm not sure if Placide has any perspectives from DRC. I am aware of rare cases of second Mpox infections being reported. It does not appear to be common, and our experience with prior orthopoxvirus infections suggests that if someone has a strong infection and mounts a good immune response, that they've got a very extended period of protection. So I think if you do see occasional rare cases of a reinfection, you've got two questions. Is it a relapse, meaning did they never clear infection and what you're seeing is a relapse because they have some sort of immunodeficiency that means that they haven't mounted a good immune response? Or is it related to immunocompromise in another way, where their immunity they mounted has decreased and now they're vulnerable again? But in the vast majority of Mpox cases, I think a prior infection is considered to be very immunoprotective.
Dr. Mbala, anything to add to that?
Just quickly, we had some cases of recrudescence that we are observing since we started our clinical trial with the tecovirimat. But as we are still blinded, we don't know if this is due to the drug or if it's just a normal situation that we are seeing. Yeah, but we observe a few cases of recrudescence. So someone who has like complete, resolution of a lesion and PCR negative in the blood, recover, discharge from the hospital, and then coming back maybe within a week or 2 weeks with a new lesion on the skin. And when we tested, we found Mpox virus. So there are a few cases. I think I can record like 8 to about 10 cases among the 570 cases that we follow, but we still don't know if it's due to the treatment or it's just due to the virus.
Okay, great. Another question that I think is a good one for both of you to comment on, and this is sort of from the Q&A and some of my own thoughts. Just interested to hear more about the observations of resistance to tecovirimat, TPOXX. Do you think that that's going to become more and more of a problem? Do you think that, as we do with some other viral infections, that we should be considering combination therapy of some kind? Just, any reflections, any data that you can recall on the situation with resistance to tecovirimat?
I can provide the U.S. experience, and I know Placide is helping to manage the clinical trial for tecovirimat in DRC. They might have some additional perspectives. TPOXX resistance appears to be rare in the United States, but as part of our national surveillance program, we are requesting that anything that's diagnosed as a non-variola orthopox virus, which is what most testing in the U.S. is, to have a specimen sent to CDC for a little deeper analysis. And so that includes sequencing, and they're able to flag sequence elements that might suggest resistance might be developing. They know which part of the genome kind of encodes for the proteins involved in TPOXX protective action. So they're seeing some of this, and it's across multiple states. It's not only in one state, for example. And I believe that there is a publication out of LA, California, that kind of first started to talk about this, and I believe they're planning a publication coming out. But the concerning thing is, among 50 or more TPOXX resistant cases, a number of them have never received TPOXX. So there's some evidence that it might be, this strain might continue to circulate a little bit at low levels. I will say there are multiple therapeutics available. So if someone is being administered tecovirimat and they're not responding, that they could add vaccinia immunoglobulin or brincidofovir, which are also available through an IND. CDC holds INDs for those. So combination therapy is a possibility. But I do think I really emphasize the need for ongoing research and development. We would like to see more therapeutics in our arsenal, because both brincidofovir has some other, potential side effects that are not great. And I think that vaccinia immunoglobulin alone has some benefit, but it's not been shown, I think, to be as beneficial as tecovirimat in severe cases. So I think that we need more in our arsenal, and research and development is going to be an important part of that moving forward.
And Dr. Placide, any thoughts on the TPOXX resistance situation?
Yeah, from our side, we did not observe, didn't check on the resistance yet, because we are waiting to unblind the clinical trial, and also to be sure to analyze, to do the sequencing on those samples. But I can say alarming to see the case of some cases of resistance reported in the US and also in Belgium, even though most of those cases are among, I think, HIV patients. But in our case, I think having only one regimen for the treatment is not, I think, the ideal situation, because I think some cases of resistance are observed even before the treatment. And so I think it's important to think about it, even if we show that the tecovirimat is effective, to treat Mpox, but very quickly the emergence of resistance can, catch us up, and so we need to be alerted, and make sure to think about maybe some combination therapy and other regimen that can be used also in order to see how we can protect the TPOXX.
Great, great, thank you. Joey, I thought I would ask you to comment on the limitations of our data, how generalizable you feel it is, and anything that came from the findings that you presented today that was really a surprise for you.
Sure, good question. I think some of the limitations, were that we did recruit a convenient sample, and I'm looking at the Q&A box too, and somebody had asked too about the low amount of Latinx people that we had that participated in the survey, and I think that was one of the limitations, right? We were recruiting primarily from Manhattan. We did partner with our prevention sites in the Bronx and Harlem, and we were hoping, and I think we did reach more diverse populations in terms of race and ethnicity in those areas. But I think that is a lesson learned of if we were to be more intentional and having kind of equity in our racial and ethnic demographics, we would explore some other strategies to make sure we reach those subgroups. And then just, we started with a higher sample size recruitment goal, and we had to lower that just because of the difficulties of recruiting on the street, outside of venues, interacting with strangers, and not approaching maybe a captive audience, which might be like an STI clinic or already enrolled in research studies. And surprising, in terms of surprising results, for this subset, I wasn't too surprised because this is in line with NYC data, and we hope to share these results with the New York City Department of Health to inform their response strategies, whether it be the barriers people noted, the attitudes they expressed in terms of hesitancy. The seroprevalence results, I will say, from what we've seen so far, and I just want to again thank the US CDC for doing the testing, are surprising, the preliminary results, and so eager to share those with everyone.
We're looking forward to that presentation in Munich and encourage people to come. I think we have time for just a couple of more questions. There was a question about the availability of vaccinations in low and middle income countries. Again, I think both Jennifer and Dr. McQuiston and Dr. Mbala may be able to comment on that. What is the situation with vaccinations in those settings?
So Placide, I'll go first, and then maybe you could give the perspective from DRC. I think the reason I've been most concerned about the rising number of Mpox cases is that vaccine continues to be concentrated and available in countries that really are not endemic for Mpox. It's an area where we've got it in our back pocket to protect ourselves, when I think its better use is in countries where their citizens are facing potential daily exposures to Mpox and identifying those at risk. And so my whole goal in working on this is trying to raise the awareness and kind of talk about the ethics involved. This vaccine should be available much more broadly around the world. There are many barriers to that. There are hurdles to overcome. There are regulatory questions that have to be answered and bodies that have to approve it. And I think a lot of times that can be quite complicated in the areas where this is endemic, but we're working hard to try to overcome that, particularly for Jynneos vaccine. And I think DRC is making strides toward having it be available in something outside of a research trial. So Placide, I'm going to turn it over to you now.
Thank you, Jennifer. I don't think I have much to add to what Jennifer said. It's important as we presented the situation that we have more cases in Central Africa and DRC mostly, and also a few cases in the West Africa, like in Nigeria and other countries. So it's important at least to have the vaccine that not only can prevent new infection, but also can prevent like severe infection, because as you know, eradication of Mpox may be very more complicated than we saw with the smallpox, since we have also here a zoonotic spillover, and as long as we don't know exactly what is the reservoir, we will not be able to really evict, you know, infection spillover. But at least if we can prevent severe infection and also mostly prevent new infection and also spread out of, you know, sexual infection, that can be a big, I can say, work that we can do, you know, and this is only if we have the vaccine available. We have many discussions, many meetings, many promises about the vaccine, but we are still waiting to see the action, and no vaccine yet available, so it's a bit complicated to really to respond effectively against this Mpox outbreak in the country. Over.
Okay, thank you. Well, we have many more questions in the Q&A, and there are some really great ones, and I'm sorry that we are now out of time. There will be a recording. I see somebody has their hand up, but I just think that in order to keep to time and wrap up, it is now I will close, and as we see here on the slide, the recording and the slides are going to be posted on the ICAP website. And I really want to thank our fantastic speakers for giving us a real, you know, state-of-the-art seminar on Mpox. We will do our best to answer questions after the seminar. We will certainly try. And I think we can wrap up here. I don't believe we have any additional bits of information to present to anybody. So thank you all. And stay tuned for announcements about our next Grand Round. So long.
Thank you. Bye-bye.